Bismillah ar-Rahman ar-Rahim. With you, Dr. Wissam Mahmoud Hassan. I am a consultant family physician. Also, I have a membership in the Royal College of General Practitioners in UK, and I am an active member in the Royal College of Family Physicians in Canada. Today, I want to talk with you about rheumatoid arthritis. Many patients come to our clinic every day with joint pain. All of us know that there are plentiful causes. So we need to take a detailed history and make general examination, also local examination for this patient with joint pain. We will talk about history, how to take history and make a general examination, either general or local later. Rheumatoid arthritis is the most common autoimmune inflammatory arthritis. So it is an autoimmune disease leading to inflammation of joint affecting. Rheumatoid arthritis has a chronic and progressive nature. Chronic disease progression leading to permanent joint deformity, destruction, and disability. The most often affected people are women, smokers, and those with family history of the disease. What is the typical presentation of rheumatoid arthritis and how is it diagnosed? The patient comes with small joint symmetrical inflammatory polyarthritis of joints. The patient comes with morning stiffness, more than 1 hour mostly, improved with activity, worse with inactivity. This is called gelling phenomenon. The symptoms of synovitis in the form of pain, swelling, tenderness on examination may be confirmed with imaging. We can confirm synovitis by imaging. Rheumatoid arthritis should be considered if there is at least one joint with definite swelling that is not better explained by another disease. The deformity of the joint is a result of injury to tendon that straightens the middle joint of the finger in the form of boutonniere deformity, affecting the proximal interphalangeal joint inflection, distal interphalangeal joint, and hyperextension. If the injury of tendon that straighten the middle joint of the fingers, affecting a distal interphalangeal joint inflection or proximal interphalangeal joint in hyperextension, that is called swan neck deformity. If the deformity affecting the distal interphalangeal joint inflection, this is called mallet finger. Deformity means permanent disability, unfortunately. To diagnose rheumatoid arthritis, we are using a scoring system. In 2020, American College of Rheumatology and the European League Against Rheumatism established criteria for diagnosis a disease of rheumatoid arthritis. We assess the patient from 4 categories. The duration of symptoms. If the duration of symptoms less than 6 weeks, we will give score 0 to the patient. 6 weeks and more, this means 1 point. Category of joint involvement. If the patient has 1 large joint, this means 0 point. 2 to 10 large joints, the patient take 1 point. From 1 to 3 small joints with or without large joints, 3 points. More than 10 joints, at least 1 small joint, 5 points. Regarding joint involvement, for patients with at least 1 joint with definite clinical synovitis, not explained by another disease, we start using a scoring system. Small joints are metacarpopharyngeal joints, proximal interphalangeal joints, 2nd to 5th metatarsopharyngeal joints, thumb interphalangeal joints, and wrist. We consider wrists from small joints. But distal interphalangeal joints, first metacarpopharyngeal joints, and first metatarsopharyngeal joints are excluded from assessment. Rheumatoid arthritis, not common affecting these joints. So we exclude these joints from assessment. Large joints are shoulders, elbow, hips, knees, and ankles. Again, in this category, at least 1 involved joint must be a small joint, and the other joints can include any combination of large and additional small joints. the rheumatoid arthritis mostly affecting small joints. The third category is serology. Need at least one to give score for the patient. We assess rheumatoid factor and anti-citrullinated antibodies or anti-CCP antibody. The patient may have low positive rheumatoid factor or low positive anti-CCP antibody. He will take 2 points. If has a high positive rheumatoid factor or high positive anti-CCP antibody, he will take 3 points. Negative refers to international unit values that are less than or equal to the upper limit of normal for lab and assay. Low positive refers to the value that higher than the upper limit of normal, but 3 or less times the upper limit of normal for lab and assay. High positive refers to the values that are more than 3 times the upper limit of normal. But sometimes the lab result come with the rheumatoid factor either positive or negative. Positive result should be scored as low positive for rheumatoid factor and the patient take score 2. The last category is acute phase reactants, need at least one. If normal C-reactive protein and normal ESR, this means 0 point. Abnormal CRP and abnormal ESR, this means 1 point. If the patient takes score 6 or more out of 10, it is the definite rheumatoid arthritis and the patients diagnosed with rheumatoid arthritis. It is important to diagnose the patient with rheumatoid arthritis early. The patients who are treated early, typically within 3 months of symptom onset, have nearly twice the likelihood of achieving sustained remission. Although rheumatoid arthritis is often a chronic disease, some patients can taper or discontinue medication and remain in long-term remission. Patients who are in remission for more than 6 months and on stable medication regimens are candidate for tapering or discontinuing DMARDs, as we will discuss. The rheumatoid arthritis is an autoimmune disease, as we mentioned before. So the patient may have extra-articular manifestations. The prevalence of extra-articular manifestations varies from approximately 8% to 40% of patients. And this means that not all patients with rheumatoid arthritis have an extra-articular manifestations. Only about 8 to 10 to 40% of patients have extra-articular manifestations in the lung, skin, eyes, heart, nervous system. The cardiac manifestations in the form of accelerated atherosclerosis and pericarditis, eye in the form of episcleritis, scleritis, peripheral ulcerative keratitis or keratoconjunctivitis sicca, hematologic in the form of amyloidosis, Felty syndrome. With Felty syndrome, the patient with rheumatoid arthritis and have splenomegaly, neutropenia, and thrombocytopenia. Nervous system, the patient have cervical myelopathy, neuropathy, pulmonary in the form of interstitial lung disease, pleural effusion, pulmonary nodules, skin. The patient may have rheumatoid nodules and vasculitis. As we mentioned before, when emphasize early diagnosis and initiation of therapy with disease-modifying anti-rheumatic drugs or DMARDs, this improves the outcome of rheumatoid arthritis. Rapid diagnosis of rheumatoid arthritis allows for earlier treatment with disease-modifying anti-rheumatic drugs, which is associated with better outcome. So, although the disease is chronic in nature, but we can taper and discontinue medication if remain in long-term remission. Before starting the medical treatment, comorbid condition including hepatitis B or C or TB infection must be screened. The disease-modifying anti-rheumatic drugs, DMARDs, we start within 3 months of diagnosis with these drugs. There are 2 types of DMARDs, non-biologic and biologic. Non-biologic in the form of methotrexate, hydroxychloroquine. Methotrexate is a typical first-line agent for rheumatoid arthritis, and then hydroxychloroquine. Biologic as tumor necrosis factor. Before starting DMARD, we use 5 to 10 milligram of prednisone daily for 4 to 6 weeks because DMARD need 4 to 6 weeks to be effective. So we use this prednisone daily for 4 to 6 weeks as a bridge until DMARD is effective. Finally, I want to assess on rapid diagnosis of rheumatoid arthritis allows for earlier treatment within 3 months of diagnosis with DMARD, which is associated with better outcome. Thank you for your attention. Thank you.